lasts as long as our inspiration from Dr. Mariko Rajamand. And our reading this morning is from the British Zionist Israel Zangwill. Come into the circle of love and justice. Come into the community of mercy, holiness, and health. Come and you shall know peace and joy. Dr. Rajamand is joining us this morning to talk about the barriers to abortion care in our own community. She is a board-certified obstetrician and gynecologist, a fellow of the American College of Obstetrics and Gynecology. She moved to Reno with her family in 2019 after finishing her residency. She grew up in Phoenix, studied biology and chemistry at Cal State Long Beach, worked in an addiction rehabilitation center for a short time between college and medical school. She returned to Arizona to study medicine at the Arizona College of Osteopathy, a branch of Midwestern University. And she served her residency in Ascension Hospital outside of Detroit, an affiliate of Michigan State University. She worked at Renown Women's Health until recently, when she left to begin her own gynecology practice. Dr. Rajamand specializes in pelvic floor dysfunction, complex gynecologic surgery, and postmenopausal medicine. She's a member of the board of the Washoe County Medical Society, which is how I met her. Her husband is neurosurgeon Sina Rajamand and founder of Battleborn Brain and Spine. They have 3 daughters and a son who, as she says, consume every moment that she's not practicing OBGYN. So, she recalls that as a child, other children would frequently come to her for advice on all manner of things. And it was a role that she took to quite naturally and led her ultimately into medicine and the helping sciences. Helping women at all stages of life, she says, is now what she finds deeply rewarding. Dr. Rajamand.
Hi, thank you so much for having me. I really am honored that Dr. Murphy had invited me to present on such a heated topic. It's definitely a polarizing issue, and I'll be presenting from the perspective of an OBGYN. So to be clear, that means that I won't be projecting, hopefully, it's difficult to do that, but any sort of my own personal faith or religious discussion. But at the end, if we wanted to have that discussion, I'd be happy to do that. My plan for this, when he and I had discussed, was to discuss the access concerns in our community. But to be able to do that, we really need to understand the medicine. And so I thought that we could take an opportunity in the beginning to talk about more of the medical jargon you might hear being thrown around. And a lot of it is construed in a way that helps benefit whatever position someone might be on. So I'd like to just go through the facts. We'll talk about where we are at Washoe County now, and then we'll have a discussion about what then putting all that together puts us at barriers in this community. So I am going to attempt to share with everyone. So give me 1 second. Sorry. Okay. Everyone can see that okay? Great. So again, we will start with the medical background so we can build our foundation, and this particular subject is really critical so that we can actually think critically, and then we can understand each side's position even better, which in this political climate, I think if anything, if we are able to take away from this and be able to understand the other side better, then we've done a good job here today. Then we are going to look at access in Washoe County currently. And then lastly, we'll talk about, as many people probably are aware, we don't currently have any ban on abortion care. So then what's the issue? If we're protected, if we're fine, then what's the problem for our community? So we're going to jump right in. So we'll start with one of my favorite quotes by Hippocrates. There are in fact two things, science and opinion. The former begets knowledge and the latter ignorance. So hopefully we won't be the latter at the end of this discussion. But and then another thing that I think challenges us in science is that we get new information and therefore the science changes. And so I think that then becomes the other side's position, that we all don't know what we're doing, but every day we're all making informed decisions using our best judgment with the information we have right now. And that is very true in medicine. So it's always, when you look back, you might have done something that was very wrong, but at the time it was correct. And so we're going to talk about what we know for today for the science. And then hopefully this debate about abortion we can have a basic understanding and then understand the subject better. So here we go. We are going to start with the medical definitions. So really try and think of this in two categories. You have voluntary and medical terminations, which is in the media or just publicly when you're discussing abortion, that's what you'll hear. But technically every form of miscarriage, every form of a pregnancy where you're it might lead to a loss, those are all abortions. So that has been an issue. If anybody is in the social media world and you're on, you name it, on what platform, we get a lot of heat for this, because many women feel that when they read their medical papers after they had a miscarriage, they'll read that they had an abortion, and it's very distressing for them. But the thing about medicine is that it can be real challenging once you have information, just because of the context of the day. But I don't think that necessarily means we need to readjust our language for, every time that a new generation becomes offended by terms. So I'll explain what I mean as we're going through all of that. But I think that as providers, we can do a better job of, when we're having discussions, using terminology that is not offensive, but in our written documents, you will definitely see the proper words being displayed. So a voluntary termination of pregnancy, this is what we think about when people just talk about abortions. Any time that a woman would like to end a pregnancy that is done for non-medical reasons. Then we have medically indicated. This is usually when we talk about the mother's life is at risk from the pregnancy. But you can also have the pregnancy itself not be compatible with life. So then people will say, well, if the pregnancy is not compatible with life, then why can't the mom carry the pregnancy until she delivers, so that we aren't in a position that we're ending it? Because it might not be compatible with life, but it might have a heartbeat. So then why are we even doing this for a mother? And the thing is, and this is an important concept that we need to consider as we go through this entire discussion, is that the pregnancy itself is a medical condition for the mother. And the pregnancy condition can have it does have basic risks, but those risks can be quite significant for the mother. So for her to continue a pregnancy that we know is not compatible with life, then we pose that question, then why would the mother continue her condition that also risks her own? So that's where that discussion comes into play. And if you haven't heard this, it's a very true thing that prior to modern medicine, pregnancy and childbirth posed a 50% mortality rate for a mother and a child. So half of moms and babies didn't make it prior to modern medicine. And so when we're talking about, again, that in a pregnancy that it carries risks itself, then you also think about abortion risks. In abortion risks, so this is, you are a mom who has a terrible medical condition, baby has terrible medical condition, somebody is suggesting to you to terminate the pregnancy. What are the risks? So we talk about it in per 100,000 mothers who are pregnant. And per 100,000 mothers, 0.6 of women who have an abortion would pass away from the procedure. So not even one person per 100,000. Whereas childbirth carries a 14 times higher risk. Now, these are still very low numbers, thank God, but it's almost 24 women per 100,000 pass away from childbirth. So if you had a pregnancy that carried a higher risk to you, then that's when we talk about medically indicated deliveries. So for example, heart failure is one of the highest risks you can have as a pregnant woman because the physiological strain that the pregnancy puts on the mother. And if you have heart failure in pregnancy, you have a 25 to 30% chance of passing away in your pregnancy. That is one of the ones that we say huge red flags. We cannot be pregnant. And I have had a number of patients who have had tubal ligations, they have IUDs, they're using birth controls, they know they can't get pregnant, and they do, because birth control, unless you don't have a uterus, you don't have ovaries, it's not 100%. So then they're in a situation which is one that you never want to be in, and is distressing for everybody who's involved if they have to figure out what to do. And in states that are now banning abortions, except for when it's medically indicated for the mother's life, now the question is at what point is the risk of the mother high enough that the legislature has decided that you can end the pregnancy? That is the sticky gray area that all of us practitioners are very scared of. And I'll talk about that a little bit more. COVID brought about some awful things that as obstetricians had to see. And you have a mom who's on a ventilator, she's pregnant, you know that they have a much higher stress on their entire system, and you have to make a decision about potentially ending the pregnancy for the mother so that she can recover from her COVID. So outside of that terminology, and again, that's where we're talking about the traditional thought of abortion, we have other types which are more natural things that we're not inducing. And the first one is an incomplete abortion. It's where the pregnancy is delivered, but the whole uterus isn't evacuated. So that's a concept that's challenging to grasp, but you can have part of the pregnancy, there's multiple parts of the pregnancy, not just the fetus itself. There's the amniotic sac, there's the, which is part of the membranes, if you've heard us talk about that. You also have a placenta. You can have pieces of any of above that don't come out completely, and that's where we talk about an incomplete abortion. This has to be dealt with, otherwise you can lead to infection. A complete or spontaneous abortion, that's your more common understanding of a miscarriage. This is where a woman unfortunately passes the whole pregnancy on her own, and nothing needs to be done medically or surgically after this occurs. The threatened abortion is where there might be bleeding, but the pregnancy is still continuing. We have a septic abortion, which is all of our nightmares. I wouldn't even tell you the things that occur with this, because it would just keep you up at night. I'll just tell you that even Dr. Murphy and I had discussed this, and some of my worst experiences in obstetrics, and something that weighed on me enough to make me not want to do obstetrics much anymore, is dealing with septic abortions, because it's one of the more traumatic things that can ever happen to a woman. Inevitable abortion. This is where we say that the pregnancy is still inside, but we know it is not going to make it. So we're very confident that it will pass. It just has not passed yet. You don't necessarily have to do anything at that point, but again, we don't want things to get infected. So many times we do intervene. A missed abortion. This is those horrific stories. Mom has no idea. She walks into the doctor. We try to get heart tones, and there's no heartbeat. So, okay, that was a lot though. Any questions on any of that? Okay.
If you have a question, don't forget to unmute yourself.
What exactly is the septic abortion? What does it mean to be septic?
So imagine that on your arm, I'm sure everybody's seen on their skin, at some point you had an infection, a little area, a little boil, and it's a little pocket of an abscess. The uterus itself, if it were to be infected, it is like an abscess that's the size of the uterus. The body just can't, medications can't penetrate that. You can't give somebody antibiotics, and this is Dr. Murphy's field. I'm sure he will agree with this. You essentially will have to do a hysterectomy, usually. And doing a surgery on a very infected patient is a real nightmare. It puts them at incredible risk in their life. They bleed. Their body is just not functioning well. So it's where the infection has spread to the bloodstream. They're incredibly sick, and that poses a major risk to the mother in overall even being able to have a child in the future ever again, because like I said many times, we have to actually remove the organs to be able to control the infection. It's more has to do with the size than anything. In other fields, when they get infected, it tends to be a little more contained. But when you understand that it's actually the infection is inside the entire uterus, that's a huge cavity depending on how far along the mother is. And even if she's only a few weeks along, we're still talking about something that's bigger than the size of your fist. So it's a big infection to try and to control. Any other questions? Okay. So now that we understand some of these abnormal pregnancy conditions, we are going to discuss how they can be managed. And I need to just make an important distinction here, because the procedures, we're talking about medication and also surgical procedures, they are all how we managed everything on the previous slide. So whether you have an abortion or a miscarriage, they are managed essentially the same. So keep it in mind when we're talking about these procedures for, this is what people talk about on these, you'll hear it on the radio or on TV, and they say how awful, oh, they did this when they took out the pregnancy and mismanaged the woman or the fetus. And I'll explain that these procedures and the medication we use are standard, no matter whether you're talking about miscarriage or whether you're talking about terminations. And why does this matter is because abortion is actually a much lower percentage of population who's utilizing the medical and surgical options. A miscarriage is very common. It's anywhere between 1 in 7 and 1 in 4 pregnancies end in miscarriage. 1 in 4 probably sounds incredibly high, but you have to understand a lot of women don't know they're pregnant. They're just a little bit late. they have some bleeding and now they're no longer pregnant. They might have never known they were pregnant. So we include that in there as well. But the miscarriage rate is very high. It is actually getting higher as women are getting older, more overweight, sicker. You know, it's becoming a problem. So we'll start with medical abortions. When we talk about that, you need to know that there are two different medications. You have misoprostol and mifepristone. And some of this might seem like, why do I need to sit here on a Sunday forum and know all this? And the truth is because you're voting on legislature about these medications. So we aren't currently, but they have been in the past. So I think that it is relevant for even the common person who's not in medicine at all to make sure that they know what we're talking about with these medications. When the two of them are given together, they are 91% effective in 24 hours of expelling the products inside the uterus outside. So that is pretty darn good. It's not perfect, but for a woman who does not want to go through surgery, who can't go through surgery, who's too sick, is not a surgical candidate, or terms that you hear in medicine, then this is a very nice option. It has low chance of having any complications when you use these two medications. Misoprostol alone is 79% effective in the first 24 hours. And there's actually 29% of all women who use misoprostol alone will end up with a complication. So that high complication might say, well, why are we even talking about this? Misoprostol is a medication that we use in labor as well. We use it in much smaller doses, but we actually use it in labor. So it does not have the restrictions on prescription for that medication. Mifepristone is only an abortifacient. And because of that, it isn't very highly regulated. So to be able to become a practitioner that can prescribe it, to find a pharmacy that actually has it, and for a patient to be able to get it, there are barriers at all three of those steps. And we know in medicine that if there's a barrier anywhere along the way, then the patient is not likely going to push through to get it. So this is one of our main problems we have with medical abortions whenever we're trying to help patients. I think that now we'll talk about who can prescribe. I'm sure many of you have had the pleasure of having advanced practice practitioners take care of you. These are physician assistants, they're nurse practitioners. They provide essential care for every community. And this is not out of the scope of their practice to be able to help a woman who's in an early miscarriage or who, for whatever reason, we've talked about all the different types of abortion, and they should be able to prescribe these medications. And depending on what state you're in, they can or cannot prescribe. In the state of Nevada, though we're progressive in some ways, we're backwards on this one, and a mid-level provider cannot prescribe these medications to a woman, which greatly limits in our community the ability to help all women. Okay, now we are going to talk about surgical abortion. With surgical abortion, there's two different terms you need to know. There's a D&C and a D&E. A D&C is a dilation and curettage. That is a term we use when the patient is less than 14 weeks. And sometimes you can add a suction to that, and that's where we talk about a dilation and evacuation. So you'll see, and I read these articles all the time, then they use the term, oh, the patient had a D&E, and we're talking about that. Now a D&C, if there's any women who are on this forum who are saying, well, I had a D&C, that's because these procedures are foundational procedures for us. We utilize them constantly. We use them to sample the uterus. We use it to remove polyps. to make sure a woman doesn't have cancer. We use them if someone's bleeding too much, so very heavy periods, someone who's postmenopausal who starts bleeding. And so these are not demonized procedures, though that's what you hear about all the time. And so if anyone were to want to limit these particular procedures, that would be a real problem for the community as a whole. So that's something that we are going to discuss, and how that will potentially affect all women in society as our training is changing, and how it will limit our ability to learn how to do these procedures safely, which affects not just women receiving abortion care, but all women who need any sort of gynecological evaluation. Who performs abortion? So we talked a little bit about who can give the medication. Now, in terms of who can actually do the surgery, it is a physician who has a license to practice medicine. Anyone, technically, who has a license to practice medicine in that particular state can open a clinic. So that's surprising to a lot of people when they realize that not all people who are providing abortion care are board certified OBGYNs. Now, it has become more popular for people to go through medical school, 4 years of OBGYN residency, and then another 3 years of fellowship in family planning, which is the term we use for people who are specializing in this area. And they are not always the ones who are actually performing the clinic abortions. Now, abortions can be performed at hospitals, and all miscarriage care that's done at hospitals. So miscarriage care done at hospitals by board certified OBGYNs, but abortion care is sometimes or not, depending on the hospital, are abortions done actually in the hospital. They tend to be training hospitals. So in our community, there's, we just added the new hospitals. So you got the 4 hospitals that are here in Washoe County, and then you have Carson, Tahoe. Abortions are not done in the hospitals. So we don't have a setup for that currently. But in the clinic, you just need to be a licensed physician. And in the hospital, though, you actually have to have board certification to be able to do any sort of OBGYN procedure. So what does that mean? Because these procedures can be really straightforward. I told you about exactly how they're fairly safe. 0.6 out of 100,000 can go wrong and risk the woman's life, but they can go wrong, and when they do, they are not great. And so we're talking about lots of bleeding, major concerns. So what happens is then the patient is transferred to the hospital, and they are cared for by someone like myself. So this is an arrangement that most of us community OBGYNs don't mind, since we don't have an interest in performing abortions, but we would be happy to take on the complications. And so then you're sending it to a surgical specialist who would then be able to manage any sort of complication from there. So we've talked about the 2 options, and you say, which one is better? Well, less than 8 weeks with the 2 medications, you are looking at 91% affected with medicine, and a very low rate of complications, about 11%. And complications can just be that the medication didn't work completely, so there's still retained products, and therefore you have to move on to surgery. But surgery is 99+% effective. Complication rate of surgery is less than 4%. It also ends up being cheaper. So while it might seem a medication might cost less, and then I would be done with it, because of the high complication rates, and again, most people are using only the misoprostol, you are ending up using the medication, going to the ER, sent home, coming back to the ER. Now you're having surgery. And this is a very common experience that women go through a horrific miscarriage, which is why it's even more distressing. And in reality, the surgery would have been better. Now, over 8, 9, 10 weeks, most people won't even provide medication for you because the rate of it being unsuccessful would be so much higher. So in that case, surgery is better. Now, when we talk about surgery in some of the termination procedures that are getting up to 20, 23, 24 weeks, then like in the state, we're protected up to 24 weeks of gestation. You have to be highly skilled and trained to be able to perform an abortion procedure at that high, or an evacuation of a miscarriage that's a lot further along. So it is safer, but you have to be trained in it. So we will talk about that as well. And we will move on to where we are in our community, but I'll just take a pause to absorb all that medical information. And if anybody has any questions, I'd be happy to answer them.
There is a question in the chat from Robin Palmer. It says, when in pregnancy, how late is medical abortion done?
So we will talk about the 2 clinics in our community. Generally, 10 weeks is most people's cutoff. If I have a miscarriage and the person's over 9 weeks, I usually tend to advise them to try the surgery. That's because the statistics tell us that over 9 weeks that your chance of being successful are even lower, but most abortion clinics will go up to 10 weeks. And then above that, it's not recommended. And now you can always try. So if you were to say have a miscarriage, you're 12 weeks, you do not want to have surgery. There's nothing that precludes us from giving the medication. It's just that you're likely going to be a lot less successful.
Mariko, there seems to be some confusion over the difference between D&C and D&E. Would you describe the difference in the procedure?
Sure. A D&C is where we are dilating the cervix to be able to access the uterus with instruments. The cervix itself will be about pinpoint, just enough to get some bleeding out when you have a period. When you're pregnant, it's a little bit bigger, but it's still not enough to be able to introduce an instrument. So we have to dilate the cervix first. And then depending on how wide the instrument is, then we dilate further along. A curettage is where we're doing a gentle scraping of the actual lining of the uterus to release the contents of the uterus and remove them that way. And when you're lower in your gestation, that's usually all that's needed. A dilation and evacuation is where you are definitely above that 14-week mark. You will be utilizing different instruments to be able to evacuate the contents because the contents are bigger. So without getting more gruesome, these are things that honestly I don't think people should think about. In the context of medicine, we are able to compartmentalize our thoughts. I know I'm helping a woman, I'm removing tissue that could potentially hurt her. I know that that's what's going on, but when we're sitting here having a discussion on a Sunday, of course your thoughts are, it's a baby, it's parts, it's things, and that's a lot more challenging to consider, but that is much more of what goes on after 14 weeks. So that's the evacuation procedure.
Now, is the evacuation done by suction?
Suction and curettage together, as well as just gross removal of, and gross is not like icky gross. Gross meaning the physical larger contents.
And how do you make sure that all of the products of conception, in fact, have been successfully removed?
If you know that you are having a higher order So that's a further along gestation, pregnancy, tissue removal. It's almost always done under ultrasound guidance. If I have a patient who we've done medication, she, delivered most of the contents at home. Now we're realizing that there's something left over and there's not much in there. Those can be really hard to get out. They become scarred down in the uterus. And so even if they weren't far along, I use an ultrasound for that. I believe it's pretty standard care for an abortion clinic to be doing ultrasound. So it's not good for the patient, not good business to leave something behind. So I know that that's a pretty standard thing, is to use ultrasound to see what's left over.
I didn't know that. There is one more question in the chat from Terry DeBarger. I'll just read it out loud. When measuring, quote, weeks of gestation, end quote, is that usually clear in clinical settings, or is there a certain amount of wiggle room?
It is very clear when it's done by a skilled practitioner how far along a pregnancy is, but you can be plus or minus a couple of days. So when we say a patient is 8 weeks and 2 days, maybe someone else measures them and says, oh, I think they're 8 weeks and 3 days. So you're usually not off by weeks, but you could be off by a day or two. That generally doesn't affect people much, but it does. Say you were 10 weeks in 1 day and you went to have an abortion procedure. Well, they would say, we're not going to give you medication. You can only have surgery. So it is a problem. And when we talk about cutoffs for which option you can have, and in ultrasound and in obstetrics, we always quote 15%. So you can be off by 15% either way in a gestation. But when you're early on in the pregnancy, it's not 15%. So anytime in that first trimester, if we are able to date your pregnancy, then we are 99+% correct that that is the exact gestational age, regardless of the woman's last menstrual period.
Mm-hmm.
Anything else?
There's nothing else. Oh, just as I said that, we have another question in the chat from Robin. Weeks of gestation by LMP or US? Question mark. What if fetus is small for gestational age?
Correct. So we have rules for that. That's, if I told you the pamphlet, you wouldn't believe it. And that's how specific we are as obstetricians. So depending on your gestation, if you are plus or minus a certain number of days on the ultrasound away from the last menstrual period, then you would either date by the ultrasound or the period. So less than 8 weeks, again, because we are so accurate, if you're more than 5 days away from their period, you don't use their period. You would actually use the ultrasound because ultrasound is that good. Now, if you found out and you didn't realize you had a baby in you and you show up in my office and you're 24 weeks, well, we can actually have a 3-week discrepancy between your between your last menstrual period and the ultrasound. So it's one of those things that the further along you get, then it is more challenging to date you. But in the context of abortion, generally we have pretty good dating early on, and so it's not as much of a challenge.
Oh, the other thing that Robin Palmer raised was what if the fetus is small for dates? Does that affect the accuracy of the ultrasound?
That is a term that's utilized once you're more than 20 weeks. So small for dates, some babies have constitutional growth restriction. That means mom and dad are only 5 feet. So the baby's not going to be really big. But there could also be a placenta that's not growing well, and placentas are not established until 20 weeks. So that's why we don't use that term until you're over 20, 24 weeks, really. It used to be not, you had to be over 28, you'd be in your 3rd trimester, but we're doing it earlier and earlier now. So 20 weeks, if it's measuring small, much smaller than what it should be, you can be measuring small for dates. But That is at 20 weeks. If that was, say, your first ultrasound, we would actually do it again in 4 weeks and figure out whether or not it was we were off on the period, or if the baby really is small. And so again, that's not so much a problem in the context of abortion. It's if you have an unsure period, then it's always going to be dated by the ultrasound. So whatever it says is what it says, even if we know that we might be off by a little bit. Anything else?
I think you can go ahead, Mariko.
Okay. All right, now let's talk about where we are now in our community. So Nevada state law allows abortion up to 24 weeks or to preserve the life and health of the mother after 24 weeks. So we're one of the few states who does allow a termination procedure above 24 weeks. In Washoe County, we do not have anybody who does that. And actually all of northern Nevada. So I have heard Clark County has a lot other options. They have a residency down there, and whenever you have residencies and training programs, you tend to have more providers that can provide this sort of outlier care, but nothing around here that would be able to take care of that. Just so you know, when you see these things, you're reading an article and they bring up 442.250, that is actually the law. So it went into effect. It's now embedded in our Constitution. In 1990, they approved the Freedom of Choice Act, and it upheld their right to abortion, even when Roe v. Wade was overturned. So back in 90, we were thinking far in the future that that could possibly happen. That is when they talk about question 7. So question 7 is referring to our Freedom of Choice Act, where we just reaffirmed our rights. Then in 2019, there was a Senate bill that's called the Trust Nevada Women Act to decriminalize medical abortion and remove informed consent laws and other barriers to access reproductive health. So what is that? In 2019, what they realized is yes, we have protection for women to be able to have it performed, but there was still jargon that was in the legislature that if you actually were providing the abortion care, then you could potentially be, the suits could be taken up against you. So they made sure that anything that was in there that was old written words were removed from our Constitution. Informed consent laws. So there is something that's on the books that says that less than 18 years old, you have to have a parental consent. And, I'm a parent. I can't imagine my child going through any of these things on their own. So this is a hard one for any parent to understand of why would you want somebody who's less than 18 being able to perform these procedures. But in our laws, they did remove the informed consent laws, but it's not removed in a way that it couldn't be reinforced later on. So that is one of our laws that could potentially be adjusted by depending on who's in power at the time. Now we know that Roe v. Wade was overturned on June 24th of this year, and then 4 days later, our governor issued an executive order. And he wrote in the executive order to protect patients and healthcare providers from other state prosecutions. So one of the ways that we're getting challenges in our community for people who provide this care is that if a person from, say, the state of Utah came to Nevada and they had an abortion, it is illegal, and they prosecute any provider who performs that care. Well, now is a provider in this state liable, and can they be prosecuted out? And so his executive order says that they will not cooperate with any outside state to provide any information about any provider nor any patient, so that they cannot be prosecuted outside of the state for what occurs lawfully in our state of Nevada. So
Yeah.
why do we hear on the computer, on our phones, why do we read these things that people are saying, hey, I'm against abortion, you elect me, I will overturn things in Nevada? They can't do that, actually. So just to be really clear that our protections are embedded, and that we have it written in such a way that the only way that these laws can be overturned in the state of Nevada is if they are brought to vote by the people. So nobody can come in and actually just flat out right overturn it by any act. They couldn't go through the judicial system. It wouldn't be an elected official. It actually has to go to the people of Nevada. The most recent poll I could find, it is 69% being a pro-choice in our state of Nevada. So that would not be something that if we brought to the people and we were to vote along those lines, that would ever be overturned. So I think at this particular moment, no matter who gets elected, nobody can change the policies here in Nevada. Okay, so now we're going to talk about the clinics that are here in our Washoe County. We have 2 clinics. We first have Planned Parenthood. Most everyone is familiar with Planned Parenthood. Confusing for people to understand what they provide, but they actually provide all OB and gynecological care. They even can do the beginning of pregnancies, and ordering labs, doing providing prenatal vitamins. They do lots of contraception, basic gynecology care for somebody who's not pregnant, and then they also provide in some places abortions. And they do only elective. So when we are talking about abortion clinics, they only do elective abortions. They do not do medically induced, because those are higher risk. Those are done by high risk pregnancy doctors or by a board certified OBGYN in the community. So that's another thing to remember. Planned Parenthood is a place or any abortion clinic where you go for a voluntary termination. Our Planned Parenthood only does medical termination, no surgical terminations, only up to 10 weeks of gestation. It is performed by one physician who comes in 1 day a week from out of town and provides medication to the patients, because the nurse practitioners who are there, I actually just spoke to one recently just to confirm that all this was still accurate. They are unable to prescribe the medications, as we discussed before. The other clinic is called West End Women's Medical Group. There is one physician who's been in practice for about 40 years, and he is very close to retirement. So he was providing surgical termination up to 24 weeks, but for a while now, he has only been doing it up to 17 weeks, because like I said, as they get further in gestation, they become much more complicated, and he has chosen to not exceed that. So in Washoe County, we could only go up to 17 weeks for a termination to be performed, even though the state law allows us to go up to 24 weeks or even further. However, he just hired somebody in August. So something that's a little bit different, that I called the clinic when I knew we were giving this lecture, just to confirm again, all my information was still correct. And they did hire a second physician. She's recently out of fellowship. She will provide terminations up to 24 weeks. And she also will provide medical termination up to 10 weeks, which is something that they were not doing at this office prior. Some people ask, how much does this cost? Well, anywhere between $800 and $4,000 for a surgical procedure. So a 24-week termination is $4,000. It is cheaper across the border. So many women who are further along will go to California. Talk about the Crisis Pregnancy Center, because that's a relevant discussion when we're talking about abortion. Our communities and centers that are trying to help women in their pregnancy and support them so that they would not pursue an abortion. And we have one clinic here in Washoe County, and their goal, and it's obvious that that's what their goal is, that they want to support the experience and deter a woman from proceeding with an abortion. So these are state numbers. I will tell you, I could not find the numbers for Washoe County only. So these are for the entire state of Nevada. Clark County does a significant number of these. So our numbers are much, much less. I tried to get some numbers from the clinics that we have, but they were just letting us know that in comparison to what's going on in Clark County, where a lot of people come in actually from out of state, they have a larger influx of that. But here in our community, we are not picking up a high portion of these 10,000 that were done. In 2017 was the last time that there were any reported numbers. Again, not all of them are state residents. So that equals to about 16 abortions per 1,000 women of reproductive age. This is a decline by 15% from the last time they had numbers in 2014. So the numbers, at least through 2017, had gone down quite a bit. So in proportion to the country, we have just less than 1% of the entire US population, and we have about 1.1% of all abortions in the US. So it is pretty proportional to our population and how many abortions we're having. And just to, you got any family that are out of state and want to say something about our state, that we're providing all these abortions for everyone. Well, it's still proportional to our population. All right. We are now going to talk about, we've got protection, everything should be fine. So what is the issue in our community? Why is this even a problem? This is a number that is a take-home point. So I'm going to spend some time on this. 45% of all OBGYN training programs are in states that have abortion bans or near total bans. Why does this matter? If you are not trained in abortions, whether you provide the care or not, you are not getting trained to be able to do miscarriage work. Miscarriage work, again, is a much higher number of people, but you are not able to help them. So I'm going to use myself as an example. Dr. Murphy said that I trained in just outside of Detroit. Ascension Hospital is the second largest hospital system in the whole country, and it is the largest Catholic hospital system. So I am a Catholic hospital trained OBGYN. I was not allowed to do tubal ligations, contraception, unless it was helping any sort of abnormal bleeding. I couldn't use anything for solely contraception, and I could not perform any abortions. So I had no training. What that ends up doing is it limits people's skills to be able to provide miscarriage surgical care above 14 weeks. 14 weeks is usually our cutoff because you're out of that first trimester where it becomes much more challenging. So now let's fast forward. Here I am, an OBGYN in the community, Renowned Women's Health. We have the highest OB population, or at least we did when I was there. And I have a patient who comes in who's 18 weeks along and has no heartbeat. Well, I am unable to provide them the surgical care that we know statistically is better and safer for them. They're distraught. You can't imagine what's going through their mind. The husband, everyone's in tears. And now I have to say, okay, let's go to the hospital and we're going to labor in the hospital and deliver the baby. And by the way, there's at least a 29% chance that you'll have a complication. It'll most likely lead to excess bleeding and we'll have to do a D&C after the procedure. So this is not just me being Catholic trained, because you might say, okay, so I'm one of those 45% people, but thank God we got 55% who are trained. Actually, in Washoe County, outside of the abortion clinics, which I said only do elective terminations, there is only one provider in the whole community that will do second trimester surgical terminations. One. He's very busy, and I'll just say that it's a real challenge to be able to get your care over to him. Not because he doesn't want to help, but he just can't take care of the entire county. So the majority and the standard of care in our community, if you have a second trimester loss, you will be getting medication. And that's the biggest take-home point I can let everybody know, is that without training, without or I should say with these sort of restrictions, we are limiting the care we are providing for all of our women in the community. Another issue, I know we're not a highly diverse state, but we should always be concerned when any law hurts vulnerable citizens, and the abortion restrictions are classic examples. Any woman who can take time off of work, who can fly to another state, stay at a hotel, pay thousands of dollars of cash for a procedure, will continue to be able to do so. Who will not be able to, it's usually women of color, women of lower income, will not be able to continue to get the care that other women are able to get. Something that we need to understand is that in the United States, we take a lot of pride. Oh, we have a system in place. It's not perfect, but I can get the care I need, and we have the best of this, best of that. Well, in the world of obstetrics, we're doing worse. So we have the highest morbidity of any developed nation. We're the only developed nation with morbidity that is increasing, not decreasing. So we aren't getting safer to have babies. We're actually getting less safe to have babies. And then you add in this concept that it is more challenging to be able to obtain a medical abortion. That also, so when they say that you need to wait until there is a threat to the mother's life, at what point? So, I mean, I could go through lots of horrific stories that I don't want to just ruin everybody's Sunday about, but in one that really sticks out to me, I was in training. Again, we can't do abortions there. I had a mother come in. It was her 6th pregnancy. First 5 were all miscarriages. She wanted that baby more than anything. She's 20 weeks and her water breaks. We know that when the water breaks and you're that early, the baby cannot develop normally. So we would say that this pregnancy is not compatible with life. They don't develop the lungs to be able to breathe because you need the fluid around them. They don't develop hearing, eyesight, that sort of thing. So this was going to go in a bad direction. Are there unicorns out there that a baby was born normally? I've heard of these things. I have yet to see them, because what happens is now this water sac is broken. It's open to the vagina, and now we have a risk of infection. And she did get infected, and to limit all of those terrible, gruesome thoughts, she ends up dying. And that's because we had to wait until she was septic to be able to intervene and remove the pregnancy. So we have to wait until the woman is in the ICU on death's door. That is what the laws are written as, because it doesn't make it clear. If I know she has a potential to become sick, can I then terminate the pregnancy? And also, who's the one practicing medicine here? Is it the legislatures who are making these decisions? They don't have a license, but I had to call the ethics committee. So I'm calling the hospital's ethics committee to be able to get permission to practice medicine to save this woman's life. And the person on the other line of the phone wasn't even a physician for them to make these sorts of decisions. That's the sort of things that we're going to be dealing with a lot more. So again, we talked about medically indicated terminations will decrease because of these laws, and now we're going to increase our morbidity and mortality. Again, we're more overweight, we're older when we get pregnant, we have more illnesses at a baseline. All of these things are not good in a really challenging physiological state, such as pregnancy. So here we are at our final take. Abortion restrictions limit basic medical care to women. I hope that I've made that point pretty clearly, that whenever we're restricting care for a certain subset, we need to be able to look at the whole under an umbrella and who will be affected by this. And unfortunately, all women are being affected by this. Medical care should be guided by sound science and each patient's individual needs, not by legislative restrictions, which is what unfortunately we are dealing with right now. And Dr. Murphy and I were talking in the beginning, and at the very beginning I had the Hippocratic, or a quote by Hippocrates, and we all take a Hippocratic oath. And I was saying, and which is very true, that when you take that oath as a provider, you do have to put aside your own personal faith belief, opinions to be able to provide the best medical care for your patients. And though I don't have to provide abortions, I do need to get the patient to a provider that can give them the care that they need. And that's where we've lost this disconnect. And unfortunately, I think that all women are going to be suffering. And I say women through this whole thing, but don't forget, there's lots of kids that are involved as well. Young women, young adults who are unfortunately pregnant, who are also dealing with these sorts of repercussions. So on that happy note, do we have any questions?
Yeah, I think we
Before
should.
I'm sorry, I
Thanks.
was just going to flag you that it's 10 o'clock. So Kevin, I know there's lots of conversation in the chat and you will guide us accordingly.
Yeah, well, let's take a little extra time. I think it's worthwhile. And before doing that, let me thank you, Mariko, for a very clear, objective, and realistic assessment of where we stand right now. I have a question that I don't think has been covered, and that is for the woman or couple who order an abortifacient by mail order. What are they going to get?
We don't know. I have had, that was never a question for us, but now that you'll have a patient who comes in who's bleeding terribly, and you can tell by the questions they're answering that this probably wasn't something spontaneous. And you look inside with an ultrasound and essentially the entire contents of the pregnancy are still there. So I don't know what medications they're getting. It's causing some sort of a process to expel the contents of the pregnancy. I don't think that they're totally effective, but then again, if they are, they're not coming in to see me in the office. So it's an unfortunate situation that women will just be rolling the dice on that one. And I bet they don't know that they need the two medications to be effective. And I'm sure that their online dealer isn't telling them that either.
So you think in many cases, they're just getting one of the two
Yes.
medications?
Yeah, I'd venture to guess they're only getting one. There are some people who would do mifepristone alone. I didn't mention that. It's not as common, but you can. It's less effective than, again, the two of them together.
Mm-hmm. Okay, and even with the other, it's 79% effective. Now, does that mean that there are retained products of conception in the other 21% of cases?
Yes. Yeah.
So that requires medical attention.
Yes. And you can try medication again, but usually if you fail the first time, then you'll fail the second time. So we're just prolonging it. It's more distress, more bleeding, more risk of infection. So moving on to surgery would be the best move.
So Robin Palmer says, I fear that in states that restrict all abortions, that women who experience a spontaneous abortion could be liable for the fetus's death. Do you have a comment on that?
I think that goes back to your mail order medication question. How do you prove that you're having a miscarriage and you did not induce it yourself? You can't. Yeah, they're not medications that you do a blood test for, which again, if we go down that route, we're in a real state of this society. So those are fears that are meant to be placed in a woman's head so that they don't even attempt these sorts of things. Because fear is much more convincing than even any state law.
One of the questions that we like to routinely pose in these Sunday forums is, what solutions are there for the problems presented? And I can see from earlier in your talk that one legislative solution to a minor problem is allowing nurse practitioners and PAs to prescribe medical abortions. What other legislative solutions do you see are needed, or other kinds of solutions?
If I'm speaking only about our community, then recruiting providers who would want to practice medicine here. That comes with, people are looking at a lot of things. Hey, no state taxes. Okay, great. What are the chances of you getting sued? These are, things that physicians think about. What are their cap rates? So there are ways to make this area more appealing for providers who do offer that care, since we are protected, but we just don't have that number of physicians. And this isn't saying, okay, we're going to go recruit all the Dr. Deaths around town so we have a bunch of abortion clinics. I'm talking about getting providers here who are OBGYNs who can provide that sort of miscarriage training, or somebody who needs a medical termination. We don't have the skill set, we don't have the population to be able to help everybody in the community. So that would be really helpful.
Okay. So, well, let's take one more question. I see Nancy Ann Leader has her hand up. Nancy Ann, just unmute yourself and tell us.
I actually wrote it also, but I think that the common political discussion does not include all of the negative effects on women's bodies when they're older, which were caused originally by pregnancy and or childbirth. And I don't know why that discussion is left out. Not in today's discussion. Today's discussion was great, by the way, thank you. But I think that politically, those points are not raised.
Yeah, I think that the pro-choice side could adjust their language to make it more clear of what they're talking about, because they say, my body, my choice. Well, maybe take it to make it clear, my body. So what you're saying, by all the people in suits who are making these decisions, is that I have to take on a medical condition that will potentially risk my life when I don't want to. And then I think that opens the door for a different discussion to say, okay, what are the physiological risks in pregnancy? And then it's a whole other world of discussion. But you're right, that's not part of the context when we're going back and forth, that's for sure. Because everyone says, well, it's natural, it's, the woman did it and they need to take responsibility for it. There's a fetus with a heartbeat involved, they have rights, and that's kind of where our basic discussion goes.
I'm assuming that your practice is involved in this older women's medical issues that are initially arising because of pregnancy and childbirth when they were young.
Right. So exactly. It's not often that you say, hey, to a 20-year-old, hey, just so you know, if you decide to get pregnant and have children, you might poop yourself, leak urine, have things fall out of your vagina. Anybody who's older might be giggling that, yes, those are things that we've all gone through, and very, very normal. And it is what happens when you have a child, when you have a human being expelled through your vagina, things just aren't going to be exactly where they were in the beginning. And yet that's not exactly a discussion that people have, though. That's why some women might come in and say, hey, I heard these things exist. I want a C-section. I don't want to have things go through the vagina. So that's a more of a common reason someone might have an elective cesarean section, trying to avoid that. But even a woman who has a C-section doesn't avoid those risks as well.
Well, I think we all regret having to bring this discussion to an end, but Mariko, I want you to know that the chat box is just full of praise for an excellent presentation. I think one of our very best, and there's even a longing for more. So maybe as things develop, we'll invite you back in the future. So
I'd be happy if you have burning questions I can answer by email if you wanted to. So you can let me know about that.
Okay, all right. Anyone is welcome to email me with questions that I will pass on to Dr. Rajamand then. And Mariko, thank you again very, very much for an outstanding presentation. Lauding it especially for clarity.
Absolutely.
Good. All right. And the light has persisted, I see. Okay.
Thanks, Kevin. This was great.
Yes.
This will be on YouTube later.
Yeah, my wife reminds me that I should mention the next Sunday Forum, which is October 2nd. And that will be Karina Black, Dr. Karina Black, Executive Director of the International Center of Northern Nevada, who will be talking about the global refugee crisis, and with some focus, but not exclusively, on the Ukraine and Afghanistan. So hope to see you all there. And
is that the hybrid?
What's that?
Is that the hybrid session, or is that still virtual?
Oh, no. Yeah, Philip has promised to train me in the hybrid presentation from Star King in November. We might be forced to do it sooner, but we'll see. It's a question of time commitment here. But eventually we will have a hybrid Sunday Forum. So thank you all very much, and see you at service.
Thank you, Kevin.
Yes.
Bye.
Thank you. Great.